Thank you, everyone. Good afternoon and welcome back to the Systems and Sustainability Echo. My name is Shreya Prasanna and I will be facilitating our discussion today. Some housekeeping before we begin. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate at the bottom of your Zoom window and select the Show Captions option. We are recording these sessions for later distribution through the BeWell YouTube channel. Any information you put in the chat will not be shared in our recording. As always, please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is in the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to join by video, especially for the discussion portion of our session. That said, regardless of how you've shown up today, we're just as happy that you're here to learn alongside us and to share your perspectives in today's discussion. Because there's a lot of us here, we ask that you keep your comments brief to allow space for others to speak up as well. You can also use the chat feature to share your comments and questions. Please note that no protected health information is allowed in either the chat or our discussions, and that includes sharing names, emails, exact dates, or any other medical information that can easily identify an individual. To help us with attendance, please enter your name, email, and affiliation into the chat. We appreciate your support in helping us fully capture this record. To all the BeWell Texas providers, please make sure you identify yourself during the session, or if you're joining via phone, please email your phone number and name to bewelltx@ithaca.edu. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it to be entered into a drawing for a $30 Walmart gift card. Our didactic today is about changes in Medicare reimbursement, expanding your behavioral health workforce. After that, we'll have some announcements and then hear a systems case from our learning community. As always, I encourage you all to share your questions, feedback, and guidance for the questions raised by our case presenter today. We're all learners and we're all teachers in this space. And with that, we will do some introductions. Matt.
Hi, everyone. Good to be with you today. I'm Matt Rosa. I'm a consultant. I work in the areas of quality improvement, process improvement, evidence-based practice implementation. My background's in clinical social work, agency administration, and governmental planning. Thanks.
Thank you so much for joining us. Cathy.
Hello, everyone. Great to see you again. I'm Cathy Hudgins. I'm also a consultant. My background is I'm a licensed professional counselor and a licensed marriage and family therapist. I've worked in integrated care for 2 decades as a provider, a program builder, trainer, professor, and focusing on mental health and substance use disorder treatment, integrated into medical care and then as co-occurring.
Thank you so much for joining us. Lesley.
Hi, everybody. I'm Lesley Manson. I'm a licensed clinical psychologist. My background is in healthcare and healthcare management. I'm an expert in building integrated care facilities as well as building fiscal sustainability for mental behavioral health, medical, and substance use facilities. Thank you.
Thank you so much. Tonya Granger. Tonya, could you please unmute?
See, that's because people tell me I talk too much. I'm so sorry. I'm Tanya Granger. I'm a licensed chemical dependency counselor and alternative funding coordinator for Texas Clinic Healthcare System. I've been with them for a little under a decade, and we specialize in a wide array of medications for our population here. We've been in business about 40 years.
Thank you so much for joining us. And Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am a program coordinator for CSTAT here at UT Health San Antonio. Welcome, everyone.
Thank you. And with that, we will get started with our didactics. Lesley and Cathy, you can take it away whenever you're ready.
Thank you.
I'm going to go ahead and pull the slides up. So give me just a moment. And there we go. Can everybody see it okay?
Yes.
Okay, welcome. And today we're going to be discussing changes in Medicare reimbursement, so ways to expand your behavioral health and substance use workforce. And we'll also be touching on Medicaid as well. We do not have any disclosures to note. And Cathy, take it away.
Hello again. So the three main topics that we'll be discussing today are the changes of Medicare mental health reimbursement and the covered provider types that were included in that expansion. We're going to also help describe the services and individual qualifications for Medicare coverage. And then we're also going to talk about the basic behavioral health coding that can be used with Medicare with these two disciplines. So one of the things that we thought we would start with, just to sort of get some level setting, are the different types of licensed behavioral health providers. And I know that many of you, over the past couple of years, we've talked a lot about your staffing and some of the services that you provide. And I know that some of you, or many of you, use licensed behavioral health providers. But because of the Medicaid or Medicare expansion, we've expanded our workforce because of the ability for LPCs and LMFTs now to bill Medicare, which have not happened in the past. So let me give you just a little background. I have a team of experts of each behavioral health provider type that worked on a project, and we're still working through this project to compare the different competencies and backgrounds of the main behavioral health provider licensure types: LPC, LMFT, LCSW, and clinical social workers. Clinical psychologists. And the reason we did that was because there are a lot of misconceptions and misunderstandings about the competencies because of the historical hiring patterns. You will find we did an analysis of the job ads that we found through several major sites. And most of the provider types included were psychologists and social workers. LPCs and LMFTs have been excluded because they were not able to bill Medicare traditionally. And so there was a misconception. And some of the things that we've heard in the past, especially in our conferences and in the work that Lesley and I have done in training folks on the ground, is that they didn't know exactly what kind of background or clinical training a marriage and family therapist had, or a professional counselor. So we decided to do this project. Next slide. So just a quick comparison. And I want to tell you this because it really varies across the United States. We've been in some states where a licensed clinical social worker did not have to have any clinical background to be licensed, so they didn't have to have those hours. The hours varied across the state licensure boards for things like supervision and the academic coursework required. Some states do not require that you come from an accredited program. So an accredited programs meaning, for like social work, the accreditation standards for their the CSEW, and then for psychology is APA. So if you look across all the accrediting bodies, they have consistent coursework. So what we did, we compared, what those were to sort of see the variance. This is where some of the misunderstandings have happened. I pulled Texas because I know most of the folks on this ECHO are in Texas. And I wanted to show you some of the different types of clinical hour requirements, the supervision hours. And you can see that they're pretty consistent in the clinical hours. However, how they're prescribed. So for instance, LMFTs, they have to have 1,500 direct with at least 750 couples and family hours, as opposed to LPCs that have 1,500 direct client hours, and that can be of any type. Now, PsyD, they follow APA's requirements for their internships, which are very prescriptive. And I do want to say that PsyDs are doctorate, because you cannot be licensed as a psychologist in Texas without a doctorate, and in most states that's the case. But the other 3 disciplines, LCSW, LMFTs, and LPCs, you can be licensed with a master's degree. And within that, you can see the differences in the number of supervision hours and the type. And the fact is, in Texas, your LCSWs do have to have at least 4 hours per week of direct treatment. And that would include psychotherapy or diagnosis, which in some states that's not required, which is really great. Because so you can rely on the fact that LCSWs do have clinical training and background. The other 3 disciplines do have direct client hours. And then supervision varies, but it is consistent that they do require supervision. LPCs, it's not designated the number and type as much as the other 3, but it is required. And then the academic coursework, it does, so typically 60 credit hours, which is consistent across the United States. So you do get that, consistent academic coursework. And I want to say one thing about this, though. The academic programs, even though they are accredited, even accredited programs can vary in the quality and content. And then at the end of all of this process, they do require a licensure exam. All 4 do, and they differ depending on the licensure. So in sum here, just to wrap this part up, in Texas, your 4 major, behavioral health provider licensure types are fairly comparable. So one is not going to be a whole lot better than the other necessarily. It'll depend on the individual, the type of experiences they've had. The only difference is the PsyD is actually a doctoral level, and they have a lot more experience because they have a master's level, experience on top of their doctoral level. Next slide. The one thing I do want to just focus on just a little bit is the content of what they're learning. So when you get someone who is newly licensed, or they're provisionally licensed, which you can do, and depending on which type and the type of supervision, they will be in training, and a lot of people will hire someone right out of graduate school who is working toward licensure, because they can, do some work with your patients, and it's great to train your own, you build your own workforce. However, you cannot assume that they have the same level of information. Gosh, Lesley, it went back. I don't know what happened. Okay. I do want that you will have this slide, but the one thing I want to point out is that, so for go back to, social work, CSWE, they're accredited. This is for accredited programs. They do not require human development and lifespan. And they do not have a real focus on things like, consultations and the biopsychosocial. So for, someone working in an integrated care program, that's going to be pretty necessary to help them build that back in. You will also see that there is no substance use disorder or addiction prescribed as a content area, unless it is for someone that they have a specialty in their program. So they may have, most of them will have at least one maybe module on it, but do not assume that they have any information. You may have to build that in. Now, many programs do have very specific courses on substance use disorders, but not all. So I did want to say, that's where we all are common, but you don't want to make that assumption. All right. So just as an introduction to those licensure types, they pretty much have the same background. They have to have the same requirements for a lot of clinical, even though that will vary, and it will vary based on their background and where they did their clinicals. Okay, next slide. Okay, take it away, Liz.
Thank you, everybody. And if you saw me a little bit, I'm coughing in the background. Hopefully I don't have to pause to cough too much here. But we're here to teach you a little bit about the different types of licenses, and that gives you perspective of what's been happening with the Medicare changes. So if you're unaware, as of January 1st, Medicare has expanded their behavioral health contracted billing to allow LMFTs and LPCs to bill Medicare. This is a huge change, and it's been a change that's been in the works of fighting for over 30-something years by the respective guilds to make this happen. So part of kind of the fever of this, obviously, is with COVID, of what happened and all of the increased need for access that has occurred. And unfortunately, with some of the reduction in our workforce, CMS has reached out and said, okay, we do need to make this change, and we need to acknowledge that these other licenses are just as appropriate and just as trained as other types of mental health providers and provide reimbursement for their services. This will give us more access for our our patients, our community members, our consumers to be able to have access to behavioral health and substance use services. So this is something that has just occurred. It occurred at the beginning of last year, and now it is formally in place. This also expanded in the legislation about who can actually diagnose and treat and what they term as mental illness. And so that's really important to note as well. So under Medicare, that's expanded. There may be laws in your own state that conflict, or that say that individuals with certain licenses may not be able to diagnose. So just to kind of put that out there, but it did expand that, at least for the Medicare population. Okay, so if you want to look it up, if you're unfamiliar, you can look up the Mental Health Access Improvement Act and read a little bit about that. But if you are really interested, it's a way for you to potentially expand your workforce. And we're going to be talking to you all a little bit about that here soon. And so this allows for you to be considering, who do I already have at our facility providing services and direct care and support to our patients? Maybe you have folks that are already LPCs or LMFTs, and they're not providing that direct care and support related to treatment services for this population. So maybe it's time to really consider this and add them on. So this does add an ability to expand that workforce for you and expand your ability to bill for services. Okay. Reimbursement rates are lower for master's level providers. And so since these providers are a master's level license, they are lower. So what we're seeing is reimbursements are equal at the master's level, and that's what we call 75% of the rate for clinical psychologists at the doctorate level, or it's 80% less than actual charge for services. It's one or the other is what Medicare is going to pay you, okay? So typically they're about the same in the end, but it's one or the other, so you know. This adjustment really, again, reinforces this new change and adding on these new additional master's level licenses, okay? So where can you provide this billing? Actually, in any of your Medicare contracted service centers. So if you already have Medicare on board and you are a contracted provider, you can begin to consider reaching out and doing the application. In a moment, I'm going to show you the website for that. You'll also have access to the slides so that you can click on the website if you want, or maybe what I can do is once we're done, I'll pop it into the chat for you as well. That might be helpful. So whether you are an independent, smaller practice or a large scale practice, whether you're a hospital system, an FQ, or a rural health system, you can all go ahead and onboard these individuals onto Medicare if you already have Medicare contracts. Okay. What's nice is that Medicare is covering telehealth services, and I'm going to go over that as well, which is also very helpful for a lot of healthcare systems. If you perhaps don't have those folks in your current employment right now, but you need to look for expanding, maybe it's going to be through telehealth expansion to provide additional services. So the application downside is we're working with CMS, which, as you know, is bureaucracy. And so there is a little bit of a wait time and some paperwork involved, okay? It's estimated right now between 3 and 9 months to get people on board. They opened the application system out in January. Some folks were able to get onboarded pretty quickly. Others, it's give and take within these months. Okay, so there's no guarantee that you're going to get it before 3 months. There's no guarantee you're going to get someone onboarded in 3 months to Medicare. So just so that you all know that. Okay. Medicare is pressing that these individuals are part of a integrated healthcare team. That's what they want. So they want them working in medical facilities, substance use facilities, also obviously predominant mental health facilities or behavioral health facilities as well. But they have added them according to the Act as part of the definition of an interdisciplinary team as well, just so folks know that. So I'm giving a little bit of a slide here. You can download it later if you really want to look into it. I don't necessarily need to cover all of it, but this is just a little bit about Medicare coverage of behavioral health and substance use services. Okay. So that you can see that. Okay. There are some specific rules with Medicare, and if folks have questions, I really do encourage you to put them in the chat box, or when we're done, put your microphone on, because there are a little bit of rules when you are servicing Medicare patients that you also have to be very mindful of related. Okay. And that's just related to how payment systems go for them. But the key steps to becoming a Medicare provider, if you're interested, is here just basically registering their system. You have to make sure that your provider has an NPI number. If they're licensed, they should already have that. You're going to enter all of this into the PAYCO system, which if you all are familiar at all with Medicaid and Medicare, you're probably already familiar with this, and you complete this one specific form and basically move forward. Okay. It's a very step-by-step piece of that. Let's talk a little bit about Texas. Okay. So I wanted to also make a note related to Texas. I don't get to say, oh, we've expanded. So I don't get to say that, but I do get to say, if you're already considering adding on these individuals to your workforce, know that they're already covered by your Medicaid as well. So Medicaid covers these individuals as well, and they cover them predominantly in what they call psychotherapy coding, mental health targeted case management coding, and that's very specific based off population, and their outreach screening assessment and recommendation screening. Okay, codes. These are all the different coding area that they will accept these individuals to be able to bill under. I gave the dominant codes that most people will be utilizing and the most dominant codes that Medicaid pays. And if you think about how you could utilize them, Medicare also will pay for these folks in person and through telemedicine. So just so you know, and Medicare is paying right now for audio only and audio visual, okay, which is nice, okay? So just kind of giving that for folks. So if you have a Medi population, you're already seeing a population for and providing services for Medicaid, perhaps this is a nice expansion for you, okay? So this leads us to really talking about those professional implications here. And both Cathy and I really want to emphasize this expansion of access. It's really providing the ability for folks to have a larger provider pool. So more ability to think about hiring. Cathy, you had made mention something about how folks weren't really even looking in job ads for LPCs sometimes.
So you may want to expand your job ads, and also thinking about what services you can bill for. You may have thought, well, we only have an LPC, so we can't really bill for these things, now, or an LMFT. Now you can. I do want to get Leslie's take on the fact that the codes that you can bill for these new providers, you may have to negotiate that through your contracts. It may be limited based on the scope of work that you've already identified in your program or your organization's agreements for whatever you're going to provide. So you may have to reevaluate those to expand your workforce or to start billing, but don't leave any money on the table because you assume that you cannot bill for those.
So yes, as Cathy said, you could consider placing these individuals onto your workforce and really negotiating just for an individual service basis. And then you're billing for each individual service that they're providing, like fee for service. Or if you're really incorporating them into more of a larger plan or provision of care that you're offering to patients coming in, then their services will be wrapped into that payment. And so you really want to think through that and be cautious about that and make sure that really when you go into talking with them about the options, you're aware of what those different types of payments could be. So we do always recommend for organizations to consider, okay, what is the current going rate for this individual? How much are they going to cost me to have them brought onto our organization and provide services with their benefits, et cetera? What is that reimbursement rate going to look like? Okay, and typically it's about $70 per 30 to 45 minutes of a visit with someone, and it goes up from there depending on the time a lot. And so you can do some kind of simple math to see, is this going to be something that is going to be sustainable at your organization? And then if instead it's going to be wrapped into getting a larger bulk payment for perhaps some inpatient or other types of services that you have that has some sort of wraparound payment structure to it, is that going to be worthwhile and sustainable for you fiscally as well to bring them onto care? And again, it may be something that you bring on contractually through telehealth to be able to expand services and reach, if that's helpful as well, since right now they are paying for that. Now they are going to be looking, Medicare is going to be looking into whether or not that's going to be sustained again next year. So we don't know what the future will hold, but most people are saying audio and audiovisual is here to stay. So we will see as the years unfold. So of course, this is definitely helpful with, again, just looking at our enhanced continuity of care services that we can provide to our patients, as well as this helps really move parity for all of our states and through licensure and payment structures in the United States, which is a huge movement for parity for folks.
The one thing I do want to say also is that, so thinking about the opportunities for your counseling and MFT folks, if you do take on a provisionally licensed, make sure that you are looking at the supervision requirements for that type. You don't want to get someone into a situation where they are working toward their license and you aren't able on site to provide that type of supervision. But for me, I would love to build my own workforce so you can help them, especially if they want to also qualify as your addiction type of certification. It's really a great stepping off point, but also looking at anyone that you hire that is licensed about their background and their competencies.
So just lastly, we wanted to provide you all with some resources. So I did make sure all the links were in here so you can peruse them. There's many slides with the links as far as enrollment and even some of the trainings the CMS has provided for organizations to review. There's also a link for just the newsletters from CMS as well. So there's a few different links on here for you all to be able to see and review. And I wanted to stop here because I know we're almost at time. Do folks have questions related to any of this expansion or other questions related to licensure?
Thank you so much, Lesley and Cathy. This was a very informative presentation today. I will open up, as Lesley mentioned, the floor for some questions or comments.
I'm just glad to get some help because I'm usually the only LPC on staff. So everything that nobody else can do or wants to do comes to me. So I'm glad to get some help.
Yay, fresh legs.
Yep.
Fresh legs coming, yes.
Yeah, with this, I think in another 5 years, we're going to start to see more and more of the workforce coming in because of this expansion. And especially within even universities, students were being really taught, okay, sure, you can go down any of these ways, but if you go down and become an LPC or MFT, by the way, you can't, work in government, work with the DoD, work with, right, Medicare, right?
Well, we've been shut out for years.
Yeah.
But there, and something that may be coming, and Lesley probably knows this much better than I do, is that there is a proposal out there for a master's level licensed psychologist. And the curriculum has already been built, and a lot of the academic programs are really thinking about that. So hopefully the states will follow that, and that way it'll be easier to get psychologists who can do more testing if that's something that you feel, would be appropriate for your organization. So that's coming, and that way it'll be easier to compare these types of licensures when you're looking at hiring someone, and then the reimbursement rates should be a little higher for them as well.
Yeah, I can always speak on that one a little bit later. I know we've got to close up for our case here. But thank you. If anybody has any other questions, you're welcome to also email us separately or email the hub team here, and they'll get it to us as well, and we can answer folks' questions offline as well. So thank you, everybody.
Thanks, everyone.
Thank you so much for this presentation and the questions. And yeah, please keep the questions coming in the chat. Lesley and Cathy can answer as we go. In the meanwhile, we will move on to the next part of our session. Taylor, if you could please share the announcements from BeWell. Thank you so much. To claim your CME credit, you must text by midnight tonight. Please text attend 10095857 to 844-502-1338 to record your attendance. Next slide. The Center for Substance Use Training and Telementoring offers technical assistance for various SUD needs and topics via our team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. And we'll drop this link in the chat as well. Next slide. Join UT Health San Antonio School of Dentistry for a statewide dental opioid summit on May 31st, 2024. And this event is open to dentists, dental professionals, as well as physicians and other professionals working in SUD. You can register for the summit using the link in the chat. Next slide. Join us on Thursday, May 30th for an exciting panel conversation with 3 experts across Texas, leveraging innovative models for the delivery of medications for opioid use disorder in underserved rural areas. To register, visit texas.org/sessions. Next slide. Join CSTAT for our session titled Communicating During a Public Health Emergency, Strategies for Effective Culturally Responsive Interventions. This will be on Tuesday, June 18th at 12 noon Central. And you can register using the link. We will be dropping this in the chat as well. Next slide. Please join us for our next Systems and Sustainability Echo on Thursday, June 27th at 12 noon. And with that, we will move on to our case for today. Our case presenter, Tanya, works with an organization that provides medication-assisted treatment for people with SUDs. Tanya, please tell us a bit about your role in your organization and what are some of the challenges your organization is currently facing. Could you unmute yourself, Tanya?
I just seem to really have an issue with that, don't I? Again, thank you guys for asking us to be here. My name is Tanya Granger. I'm the Alternative Funding Coordinator and Counselor for Texas Clinic Healthcare System. Just a little brief overview of who we are. We've been in business now about 40 years. We are the largest OTP in the city of Houston with a census of over 500. We have multiple streaming funds. We have Medicaid, Medicare, OTS, NAS funding. I really love the NAS funding that captures pregnant women, postpartum, and parenting. We also have the BeWell contract. So we have MedAUD, where we can service alcohol use disorder via Vivitrol, as well as BeWell for OBOTs. We have 3 OBOT locations, office-based opioid treatment, Melbourne, Melbourne Galleria and Grand Parkway. We have 5 physicians, 14 counselors. We have 6 nurses, administrative staff, and a wonderful leadership team that I think I saw on the call. So if I'm missing anything, guys, please feel free to help me out, because a lot of this is above my pay grade anyway. So one of the things that we do, we are the largest provider in Houston, and a large portion of our population is dealing with homelessness and indigency. We have systems where we are connected with Houston Recovery Center, where we will get people coming in, being homeless people going into the sobering center, needing services. We have a connection with UT as well. We have a partnership with Santa Maria Hospital, where we deal with our female clients, both specialized females, adult and pregnant and parenting women. And we also have connections with a couple of the treatment facilities here. When we have clients that are interested in going into residential treatment, we work with Cheyenne Center and CenterCore, and we sort of service coordinate that medication so that they don't have to detox off of the MAP product in order to go into residential. We provide a minimal delivery service. We make sure that the meds remain there for the client if they want to go into residential. One of the things we do is we have several Medicaid, Medicare providers. So we're able to take people that have different providers, not just one specific one. And we, again, have the Vivitrol and buprenorphine in our OBOT offices, where we also offer the Be Well funding. Part of our sustainability, and if I've missed anything, guys, and you're here, help me out. But I think the major crux of our sustainability, one is, we're the largest, and we offer we have funding, and that seems to be a big barrier for folks in Houston in terms of being able to pay for it. One of the challenges is that because we do have multiple funding sources and we have the availability, it's not always transportation conducive. So of course, transportation is a huge barrier to services with our clients. Even our Medicaid, Medicare clients that receive transportation as part of their services, it's not always coordinated well, and they really struggle to get here. It just gets to be kind of a mess. One of the things is we really try to help with, giving housing referrals. The great news is these folks will get housing. If they were homeless, they may have been staying under the bridge, very close to the facility near our train, because we're right off of the rail. When they actually get housing, they will house them somewhere 30 miles away, 20 miles away. And then transportation becomes an issue for those folks that were already here doing very well, got housing, which is what we wanted, but they housed them very far away. And so those are some of the challenges that we see. The successes, I think, are rooted in our service coordination. We have wonderful relationships with Ben Taub Hospital, with Harris County Jail. So we're able to service pregnant women who are incarcerated. And we have this wonderful program where they are brought, and it's great the way that we coordinate, because the client may start with us just walking in the door, and they're pregnant, they're not in prenatal. We'll then coordinate them to Ben Taub. Ben Taub will then begin to deal with their pregnancy needs, and then we'll coordinate to Santa Maria if they need additional treatment and go into long-term or 90-day or beyond residential treatment. So sometimes they'll start at Santa Maria, go to Ben Taub, end up with us. They'll start with us, go to Ben Taub, end up at Santa Maria. They'll start at Ben Taub, come to us. So it's this wonderful cyclical thing that we do, where we're able to capture these, particularly these women, regardless to which entity they start with. And I think that that's the most important thing, is to capture them where we get them. And that's kind of part of our sustainability, is having these relationships where we are sort of the first point of contact for MAP, because our partners understand that, we're really good at maintaining our funding sources. We have availability. We have 14 counselors, so we're able to take on quite a high census. And we also have the availability of our OBOTs. And so if they want something other than methadone, and they live in Sugar Land, or they live in Missouri City, or they live by the Galleria, they're not forced to have to come to where we are here on Fulton. We have those services there, provided they're not interested in methadone, because we don't do those in our TC practice management or our OBOTs. The other, I think, sustainable thing is referrals, really fostering relationships with the entities that are going to capture these people in a way that we won't. Houston Recovery Center is a wonderful resource for us, where they'll get people coming in off the street needing these services, and they have a direct line to us. We'll get that person in immediately, begin a process. And then once they're on the medications, we find that they're able to settle and then start looking for the mental health, which we have a wonderful collaborative agreement with Psych Matters and Harris County. We also have contracting with Harris County in their SUDAP program, where we take on, they come in for mental health, they determine a diagnostic for OUD or AUD, and they send them to us for ongoing services. So it is really our MOUs, our partnerships, our marketing going out into the community, particularly reaching people of color that don't seem to know a lot about what MAT is and accessing that. Part of our sustainability is really working on the stigma. And it's not about going into mom and dad's house where the stigma lives. It's dealing with the paramedics that come and deal with our pregnant women or people that are in crisis. Getting these healthcare systems, LBJ, Ben Taub, getting them on board because they see these people in an emergency room setting. And unfortunately, we all know that when a substance use disorder person goes to the emergency room, they're not going to quite get the same services that some other disease may. So we want them to be able to hand them a referral to Texas Clinic and say, hey, call them, they'll get you in. Because every day we don't capture these folks, we might lose the opportunity to save a life. So that's kind of Texas Clinic in a nutshell. We're large, we're fantastic, we're growing. We're always looking for new and innovative ways to service our clients. Our service coordination between medical health and mental health has grown significantly, and that has genuinely helped with our retention. The expansion of takeouts has helped with our retention because one of the challenges was retention. Again, they're doing great for a month. They get housing. The housing is far away. They're starting to miss, and we're starting to have that sort of redundancy of coming in and coming out. So the expansion of takeouts that we do very carefully. We're not willy-nilly with takeouts. Not everyone needs a handful of them. So we kind of individually look at that person and determine their ability to maintain their health with these takeouts. But having been able to do that has been huge. That has genuinely helped with our retention. I'm not sure if I've kind of covered our systems and sustainability. If there's any questions or if my leadership team is on this call and have something they would like to add, that would be fantastic if there are any questions.
Tanya, this is Cathy Hudgins. I do have a question. In your case, you were talking a little bit about you're considering private insurance. Can you let us know a little bit the reasons why you focus on Medicaid, Medicare, and the quandary you have about your all's decision making about the private.
Well, again, if Farouk Shamsi is on the call or Zishan, they can absolutely weigh in on that. And we've had those conversations. But one of the challenges that we see here, and I think it's very solvable, but we will have we don't have the challenge between funding and Medicaid, Medicare. All we do is we just make sure that because we've got a wonderful guru that's our Medicaid, Medicare administrator, and he goes out and he gets us a network with as many providers as we can possibly get a network with. So we're able to capture folks regardless pretty much of the provider they come in with. What we struggle with is when people receive commercial insurance. And a lot of times, and it's really been happening a lot, people are getting, hey, I got a call, I got Blue Cross Blue Shield. Well, that's commercial. So one of the ways in which we're able to address that is twofold. If your commercial insurance provider does not provide for MAT services or SUD, and you're able to provide for us that denial that they will not service you in that arena, then we're able to fund you through our funding sources. So a lot of times it's about kind of getting back with the client, getting on the insurance call with them, determining whether or not their insurance will cover Vivitrol or buprenorphine or methadone. And then if it doesn't, then that gives us a little bit more leeway to bring them into funding. And then, of course, we have to monitor that very closely. So we run MEVs the first of every month because someone may have Medicaid or Medicare and then they lose it. and they're in our Medicaid program and they've lost the Medicaid. We run that MEV so that we know if we need to now move that person into a funding source, because our key is continuity of care. We do not want to not dose somebody because there's a funding issue. So we are known to go ahead and eat it if we have to until we get that funding source corrected, because we will never tell a client you can't come back because your funder's not paying. We're just not going to do that. So we work really hard at making sure they're aware of the changes, keeping things current. So of course we can bill appropriately. So that's kind of how we address it. But it is a challenge because I've had people that have been in services for a long time, received the insurance, they're now unable to stay with us. So one of the things we do with that, because it's always about the client, is we have wonderful relationships with other MAT providers that do take those medications. If Olive Branch is on this call, you've got a lot of my clients up there, Dr. Mum, because we will then refer you. We will soft refer you to someone that takes your insurance. We don't tell you go out and figure it out. We've got connections with Symmetria, with other organizations that may take a Medicaid that we don't. So we are always in the process of referring out if we are unable to sustain their services for whatever the reason being in terms of funding, because private pay is not an option for many of our clients. It's simply not an option. And so we have to continue to keep them funded. I hope that answers your question. But again, there's been talk about getting commercial. Again, not my pay grade, but I'm sure it's something we'll look into, because it's always going to be a part of expanding the program and expanding access to the people in our community that need it.
So it sounds like, Tanya, that's one of the dilemmas I think that you alluded to when you shared information with us prior to our meeting today, which was your desire, as you spoke earlier, for that continuity of care, and part of continuity of care is continuity of care provider and the relationship, yes, and that can be compromised if it's an insurance that you don't take, and if you're not able to fund that person through an alternative source, then you do have to make the referral, which is certainly will provide them with ongoing care, but it's not the optimal circumstance for you and
that's
for
correct.
the people you're serving.
That's correct.
Yeah.
There are connections that are made when they're here for a while. They become accustomed to their counselor, the nurses, they get really comfortable in the process, and then it gets kind of shook up because they have to do something. So we do everything in our power for that not to be the choice. But if that is the choice, that is what we're going to do, because it is in the best interest of the client.
So what can we help you with? What is your ask, Tanya?
That's a great question, because I think just the continued expansion that we're doing in terms of Medicaid, Medicare, getting on board with commercial insurance at some point as an organization will literally kind of solve that issue. I will tell you that transportation is a greater issue than the insurance issue. So one of the things that Be Well has offered, which is fantastic, is the ability, when necessary, to be able to use rideshare services to help our clients when we can, and then to be able to build back on that at some point. So I think expansion of access to transportation, even if it's part of the funding source, give us a little bit of money over here that's dedicated specifically to transportation, because we service people that literally, folks, have to choose between a meal and a Metro Pass. And that's tough. So one day they might choose the meal, the next day they might choose the Metro Pass. So I think expanding any facility or provider's ability to accommodate that transportation issue as the greatest barrier. I see that more so than I see an insurance issue. So how can you help? What is the ask? Give us money to transport these people here that can't get here. There you go.
Lesley?
Yeah, I mean, I think the community can also chime in if they have other kind of like innovative ideas for funding for transportation, et cetera. I wanted to give another option perhaps to see if it's something that's plausible for your organization. In the past, I had, as we all do, have the same situation related to transportation for patients. One of the things that we did is expansion of our telehealth services so that individuals can do that, but that can't solve everything because they still
Right.
need to get medications, and sometimes it has to be from us, et cetera. We were able to actually we did two different programs. One is we found a prescription delivery program and teamed up with them so they actually could go where the patients are. So now the patient doesn't need to come see us because as long as we started with them, we were continuing their care, and then that service was able to deliver. And many of those services are actually covered by Medicaid, as well
Wow.
as Medicare and almost all commercial insurances. Now that and some of those actually for us, we actually teamed up with one that would do servicing in actual center areas. So they would say, we're going to park behind the bridge or
Okay.
next to, does that make sense? And so,
Yes.
so for individuals who are homeless or houseless at the time, or were in transition, they knew where to go and we arranged that with them. But again, so we could do teleservices and then do that. So again, eliminating the need to travel. The other piece that we did is we ended up putting money, and we received some money to be able to hire a community health worker. And at that point, I think it was a promotora for us. And so we had that person actually do the delivery of some of the things that we needed that prescription pharmaceutical services could not do. Now, those pharmaceutical services are now in many other states as really big businesses. This is what they do now to reduce this burden of transportation a lot and to be able to support in specific substance use facilities, both inpatient and outpatient facilities. So if you haven't looked at those at all, it might be something to really help with this. And it was a huge game changer for us to be able to have continuity of care for patients who were with us for a little bit and then due to the exact same reasons. Now they're 20 miles away, or maybe they're 5 or 10, but that's 5 or 10 over like a mountainous area in a rural area where we don't have buses,
Right.
And so there wasn't really a hope for them even to be able to take public transportation for us. So just putting that out too for folks.
Well, what's really interesting, it's kind of serendipitous because one of the conversations our program director's been having, and it's been kind of a dream of his that he would love to do, is to have the mobile mat services, to be able to take a van, and put a nurse in there and a counselor in there and go where we can have and like tell our population, because a lot of them know each other, particularly the unhoused.
Oh, yeah.
And so if we say, hey, listen, meet us on Fannin, this is where we're going to be there. If it's your day for dosing, they would be all for it. I think that would be amazing. And that is a conversation that my program director has had and a dream of his. So we'll get there. We'll get there.
And there
Really
are
talking
entities.
That's
Yeah,
amazing.
there's tons of those entities now, right? In other states. I don't know. I haven't seen a lot in Texas, but they might be in other areas. But in other states that there's actually many entities doing that exact thing.
Absolutely.
And they've expanded into other states. And I know
Wow.
some of those entities are large scale. It may not be a great want to do a partnership with them, but if you're interested, maybe it's reaching out to some of those entities that are doing it, especially those who have outside state reaches,
Yes.
and just asking them and talking to them about, would you be willing to partner up? What does that look like? Or maybe sticking safe with an entity that isn't in another state,
Right.
and just talking to them
Excellent.
about how they developed it. I know that we ended up getting a mobile van paid for
Wow.
based off of, we actually did all of the funding for one mobile van, which is very expensive, right? When you look into those mobile vans to meet requirements, they're actually very expensive and costly. We received funding through SNAP. So through
Okay.
doing it through that way. So there is ways to think creatively about how you might be receiving funding and then what you can do with that funding. So
Absolutely.
SNAP pays you for every application that is provided out, as well as sometimes the applications that are submitted. So depending on what you can receive with your state office related to that, the amount of money we received in that was enough to pay for this van. We also got some donations, but it significantly helped us to do that. And we were not receiving that money originally. So just to kind of say that as well.
Excellent. Thank you. Thank you so much.
Before we close out the discussion for today, I was wondering if there were any additional questions or suggestions for Tonya from our community here. Right. Matt, if you could please help summarize today's case and session.
Absolutely happy to do so. Thank you to Cathy and Lesley for sharing with us a very informative presentation regarding the Mental Health Access Improvement Act, which resulted in expansion of Medicare billing capacity for 2 credentials, LMFTs and LPCs, so that they can bill Medicare. This is a great opportunity for you all to expand your workforce potentially, and to create a more interdisciplinary team. They talked about the comparable coursework and supervision and training across those credentials. Important to be mindful that it might take a bit of time in order to onboard those MFTs or new LPCs, maybe 3 to 9 months with CMS. So, and to also be mindful of the economics and to consider the business case and economic models related to the percentage of reimbursement that they might receive at the master's level, as opposed to the higher credentialed or trained levels. And hopefully this will move parity one step forward. Thank you, both of you, for that presentation. And then Tanya Granger from Texas Clinic talked to us about her experiences in 2 categories: the issue related to insurance and reimbursement, billing for Medicare and Medicaid, receiving self-pay, and having some other funding streams. The challenge with private insurance and not currently receiving or receiving reimbursement for private insurance, and the need to refer out, working to try to maintain continuity of care, and to consider how best to address that, whether or not to take those additional insurances, those private insurances, as an organization. Also talked about the transportation challenges and how best to move forward, particularly given the dynamic that people who are unhoused are receiving services and then receive housing access housing, which is a distance from the actual care delivery, how to manage resources like ride shares, how to bring people to the services or to bring the services to the people. We talked a good bit about mobile MAT services and or other transportation fundings, such as the van example that Lesley was sharing. How can we figure out that dilemma around transportation, which is a struggle for many organizations as they're trying to deliver care, particularly given the dynamics that you just described, where in one stage in their recovery and in their journey, they may be close to services. And how do we maintain continuity of care when people are needing to move some distance or are located some distance from care, particularly an issue in rural environments for folks who don't have their own transportation and where public transportation is very limited. Thanks.
Thank you so much, Matt. And thank you again, Lesley and Cathy, for the wonderful presentation. And thank you, Tonya, for bringing this case to us. And thank you all for joining today's ECHO and participating in today's discussion. As a reminder to earn CME credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email cstat@utisca.edu. We look forward to seeing you at our next session on Thursday, June 27th. Have a wonderful rest of your day. Thank you. Bye-bye.